And Anna,
Hello, can you hear me? Hi, Ramella. Hello, Dr. Swami.
Yeah, morning.
And good evening here. How are you? How are you, John?
Yeah, we have the rotating panelists.
Yeah. Analyst, he wants everybody to be involved. Okay.
No, I just take the one list from you and put it there. That's it.
Okay. Next time onwards, the last.
The last list you
Yeah.
gave me,
No
I think it's
problem.
okay. I think it's okay. So how you
Let's
doing?
hope, let's hope they'll join.
So, okay. Hmm.
Hello.
Hello, Dr. Yadav.
Sir, good evening, sir. Good evening, sir.
or, yeah, I'll be right back.
Hello.
Good evening, sir.
I think I can choose background. Hello. Hello.
Sir, good evening, sir.
Hello, Dr. Swami.
Sir, good evening, sir.
I don't know whether you are not muted. Still no voice.
I'm not muted. Sir.
John, sir. Hello. 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 Hello.
Hey, Dr. Yadav, is your presentation all set?
Hello.
Do you want to check on it? Do you want to check on
Voice
anything?
is not coming.
Your voice and my voice are not heard by Professor Yadav,
Some
John.
problem with the network or
Yeah, I got you. I'm on the screen
hello,
now.
sir. I'm not able to, I'm speaking, but I think you are not able to hear me or
No, I
Dr.
can hear you.
Swami.
I can hear you. I can hear you fine.
No, this is the phone call. But on webinar, I think.
No, you're fine. You're fine.
Are you able to hear on the webinar?
Yeah.
Yes, sir.
Okay, but what
Right.
about Dr. Swami? Okay. Okay, no problem.
Hello. Good evening, good evening. How are you? Fine, fine, absolutely. Join.
Good evening,
I just
sir.
forwarded on your WhatsApp. Just see.
Yeah,
everybody
welcome,
in?
Dr. Ramesh.
Wait.
Good
Let
evening,
me
sir.
do one thing. Join.
John, good evening.
Click the Neurosurgical TV. There also you can join. Yeah. I also got error message when I clicked the link, but I went to Neurosurgical TV and through Facebook I joined. Yes.
Yeah, the links all over the place. If you see a link, click on it.
Good evening, sir. Dr. Yadav, can you hear me, sir?
Yes.
Yeah,
Welcome,
thank you.
welcome.
Dr. Jan, good evening.
Dr. Ramesh, we can hear you.
Yeah, thank you.
Your video is not there.
your camera
Yo,
working
I
okay?
just
Ramesh?
muted.
I'm
There
not
you go,
able
there you
to
go,
hear
there you go.
Good evening,
anyone.
good evening.
Yeah, good evening.
Is there any problem? Should I mean, rejoin or what? I am not able to hear anyone.
You can't hear me? Can you hear me now?
Hello?
Hello, you can? Okay, you need to fix that.
I am
Dr.
not
Yadav,
able
we
to
can hear you,
anyone.
sir.
So I
But
think
he-
I
Can you hear us, Dr.
rejoin
Yadav?
or what?
Can you hear us? You can't hear us?
Okay, I'll leave the meeting.
Yeah, and come back.
And-
Yeah, leave and come back. Yeah. That sometimes your system goes to another way of setting up the sound with like Skype or something like that. Okay, someone's in. Amat, okay, probably. You should be able to get in there, Amat. Can you hear me now? Can you hear me now, Dr. Yadav?
Is that
What?
okay now?
Can you hear us? Can you hear me?
No, but I am not able to hear the
Okay, but you have to turn your computer off.
answer or your voice. I don't know, some problem. Oh,
Okay.
Sir, you unmute, sir.
okay. I think my this voice setting was not proper.
Reboot. Can anybody hear him?
Yeah,
Reboot.
it's fine now.
Okay.
What Dr. Rasim has joined or not?
He's having some problems, sir. That link, what he clicks,
Okay.
error message in that link.
Is there anybody else on the panel, Dr. Swami, that needs to be admitted?
Dr. Rasim, he's not getting whatever link you provided, it comes as error message.
Okay, well,
But he has to register, and then Dr. Subodh Raju also. Anyway, if they are unable to join, we can continue, no problem.
okay.
Yeah, I think you can start the proceeding.
Yeah, you ready to
and
start?
join.
You
They can
ready?
join in between because your
Yeah,
talk is there.
yeah.
Yeah.
They
Okay.
can-
Okay, very good. Ready to go?
Hello.
Yeah, that's Dr.
Yeah, Dr.
Hemant.
Hemant Bharti
Yeah,
is
yeah.
the boss has
Yeah.
joined.
Good evening. Dr.
Excellent.
Hemant Bharti.
Yeah,
I have been
Dr.
trying to join, but this link is not giving me
But
any.
you're there, already there. I can see you.
No,
You have to
no,
unmute
hold
yourself.
on, you're here.
Yeah, you
No,
are
no,
here.
okay,
But-
hold
I
on,
can't
hold
see-
on.
No, I can't see my face.
Have you unmuted?
Hold on. You're not even in the panel yet.
Yeah, you have to unmute. Unmute yourself and then video unmute, voice unmute.
Sir, unmute yourself.
If you enlarge, probably you can see.
No,
Unmute.
I'm trying to
Yes,
admit him
yes.
to the panel. He has to say, yes, I want to be admitted.
Yeah,
Okay,
okay.
here he comes,
Please.
So his camera will work now.
Oh, I'll type the message. I'll type the message because that's the only way to speak to John.
Okay, Hemant, you can unmute, you can, are you there, Hemant? We've admitted you. I don't know what's going on. It says,
Yeah. Okay.
Okay, he'll try again. See, whenever you have poor connections, you can have lots of problems.
Okay. Now yeah.
Hemant, are you there?
Yeah.
Yes.
Now
Now,
you are.
Good evening, sir. Good evening, sir.
thank you for sending the link.
Good evening, sir.
Okay,
Okay.
okay. Anybody else you're waiting for, Dr. Yadav?
I think Dr. Rasim Kataria also and Subodh Raju, they must be having some, they have to register. I have already said that they have
Yeah,
to.
it takes a minute. It takes a minute to register.
And then the mail will go to their, registered mail address, and then only you can join.
No. Still then you have to send a link for panelist. Then only I could join.
Sir, I think you have to, you can send a message that please allow me to join as panelist. So they, John sir will permit, and then this is how, I mean, even I got the same thing. I have to request that please allow me to join as panelist. I will talk to Rasim if possible,
Right?
or else
You
we
may start,
start.
I'll talk to him.
Okay, okay,
If you
sir.
want
Please.
to talk, start, you start, I'll talk to him.
Yes, sir. Yes, sir. Please.
Yes, sir,
please.
that will be better, sir. Thank you,
Okay,
sir.
yeah.
Well, I
Okay.
think we'll start the.
Yeah, I'll talk to him and tell him.
Okay, sounds like a plan. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon in Miami Beach. This is Dr. John Bennett for Neurosurgical TV from Miami Beach. We have the honor of having Dr. Y.R. Yadav, a prominent neurosurgeon educator from India. And I'll let Narayan Swami to do the proper introduction and run the show. Welcome, Dr. Swami.
Yeah, thank you. Good evening. So we have this is the 5th meeting of the endoscopy in the session conducted by none other than Professor Yadav. Professor Yadav needs no introduction. And today we are lucky to have Professor Hemant Bharatiya from Jaipur, who is well-known neurosurgeon as well as a good endoscopic neurosurgeon. He has got training abroad in US as well as a lot of 40 years experience in neuroscopy. And Dr. Ramesh Chileka, again, a very good endoscopic neurosurgeon, has been performing very well throughout India and has been coming on webinar. And Professor Yadav has trained more than 850 neurosurgeons in the neuroendoscopy. He is the one who described to the world water jet dissection in the endoscopic technique. His articles on endoscopic third ventriculostomy and others have been quoted more than 10,000 times. The citation he has got, it's an honor. And he's well known throughout India as well as in the whole world for conducting webinars and workshops. With these short introductions, and since we are late, I invite Professor Yadav to give the talk, sir.
Thank you. Thank you. I think our other panelists also will join in the meantime. So I start my presentation. Can you, you got my slides and
Yeah, it's perfect.
this is okay?
Perfect.
Sir, thank you. So again, I am grateful to John sir for allowing me to discuss endoscopic surgery. And today we'll be discussing endoscopic third ventriculostomy. I am grateful to my panelists who are very, very well established and very knowledgeable endoscopic surgeon. So we'll have a good discussion. Professor Hemant Bharti sir is my senior and excellent endoscopic surgeon. Dr. Asim Kataria, Professor Bharti is from Jaipur, India, Pink City of India, and then Dr. Rasim Kataria also from there, and Dr. Ramesh Tigla has extensive experience in endoscopic surgery, and he has a device model on ETV. We should hear from him as expert comment. And Dr. Subodh Raju from Hyderabad is also excellent endoscopic surgeon. I think because of some problem, he may not be available, but hopefully he'll join soon. So today we'll talk about endoscopic third ventriculostomy, which is a very common topic, and I'll try to cover A to Z about the endoscopic third ventriculostomy. Although I have a separate lecture on complications, avoidance and their management on endoscopic third ventriculostomy, It's again a very, very long topic because I want to discuss everything which is important in the endoscopic third ventriculostomy for the beginner. We all know that endoscopic third ventriculostomy is used for the treatment of hydrocephalus. Initially, we were using shunt, but now with the endoscopic third ventriculostomy, we do more and more ETV for patients of hydrocephalus. This allows the CSF to flow directly from basal cistern, bypassing the obstruction, which is in most cases either it is there in the aqueduct or in the posterior third ventricle or in the posterior fossa. These are the best indication. So it is a treatment of choice for obstructive hydrocephalus, and it is also useful in selected communicating hydrocephalus. So please, make a note that only selected communicating hydrocephalus in which there is a bulging anterior wall of the third ventricle and the inferior wall of the third ventricle also should be bulging down. So if you have this subgroup, then ETV in this communicating hydrocephalus is also very effective, but this is not very good in acute phases of post-hemorrhagic and post-infective hydrocephalus, where I think one should go for VP shunt. And these are technically demanding. Although I can do ETV in any of these cases, most difficult cases of post-hemorrhagic and post-infective hydrocephalus, but it doesn't work because of various things which I'll discuss. So even if you struggle and do a ETV, the results are poor. So therefore, should not be performed in acute phase of post-hemorrhagic and post-infective hydrocephalus. But the results are good when there is a chronic phase of post-hemorrhagic and post-infective hydrocephalus. The indications, just to narrate them, the congenital aqueductal stenosis is the best indication. You can do it in Dandy-Walker malformation, vein of Galen aneurysm with hydrocephalus, syringomyelia with or without Chiari malformation with hydrocephalus, but not in case where there is overcrowding of the posterior cranial fossa. Encephalocele with hydrocephalus, myelomeningocele with hydrocephalus. So the congenital anomalies of the brain, if you have hydrocephalus, then usually there is abnormal anatomy, and these in such patient it is difficult to do ETV. So I don't advise beginner to do ETV in patients where there is a spinal dysraphism, myelomeningocele associated with hydrocephalus or encephalocele or other congenital malformation, because there is an associated other anomalies which make ETV difficult for beginner. In cranial stenosis, synostosis with hydrocephalus and TBM, obviously the chronic phase and not in acute phase. In TBM, we in India face a lot of problem in diagnosing whether it is a TBM or it is a incompletely treated pyogenic meningitis, which can present also as chronic meningitis and hydrocephalus. So in some case, when you do ETV, you can also diagnose, because you can see these tuberculomas in the ventricles and also in the third ventricle. So apart from treatment, you can, because diagnosis of TBM hydrocephalus sometimes becomes very difficult, especially if antibiotic is given in pyogenic meningitis. So you are in a fix whether it is TBM or partially treated pyogenic meningitis. Neurocysticercosis with hydrocephalus, posterior third ventricle tumor with hydrocephalus, any of the posterior fossa tumor or CP angle tumor with associated hydrocephalus. But here also you should be very careful for beginner. because either the brainstem is pushed anteriorly and it is difficult to do ETV, or it is distorted midline may be pushed to the right or the left side. So only after gaining some experience, you should go for ETV. The secondary ETV, either after the failed ETV or shunt malfunction, also has some problem. You have to deal with this in a post-operative period, which I'll discuss later on. The other indication is that you can do ETV and biopsy when there's a lesion in the posterior third ventricle. In cerebellar infarct with hydrocephalus, only in selected cases you should go for ETV only and not decompression. But if there is a brainstem severe compression, then it is better to go for posterior fossa decompression with or without ETV. The intraventricular hematoma with obstructive hydrocephalus, NPH with bulging anterior wall and the floor, and in some cases of multiloculated hydrocephalus, either it is because of infection or IVH, and in slit ventricle syndrome. But if you have to do two things, you have to do a ETV, the trajectory will be different. And when you do biopsy of third ventricle tumor, then the trajectory is different. So there are options available if you want to go for single burr hole, especially when the foramen Monro is large, then you can choose a trajectory in between. There is a trajectory for ETV, the B, and there is a trajectory for biopsy. So in between, you can choose a single burr hole, provided the foramen Monro is large and you can move your endoscope anteriorly or posteriorly. And the other trick is when you go for ETV, you keep the working channel anteriorly. And when you want to do the biopsy, then you rotate the whole thing, set the working channel should be posteriorly. So you buy about 5 millimeter and you can move little bit about 5 millimeters. So 5 millimeter of slow movement can be tolerated by foramen Monro. So there are three options. One can go for single burr hole when there is a large foramen Monro, or you can have two separate burr hole for different purpose for biopsy and ETV, or you can do single burr hole and use flexible scope, because flexible scope tip can be moved, and with flexible scope you can do both ETV and biopsy. But the vision usually is not so good. But now with chip on tip and with high definition camera, things have changed. You can also do ETV in slit ventricle syndrome, and how to do that also I'll discuss in my subsequent slide. So multiloculated hydrocephalus after infection or hemorrhage, IVH, intraventricular hemorrhage, is a difficult entity, but the endoscopy plays an important role. You can break the septas and make these multiseptate hydrocephalus into unilocular cavity, and then you can put in a shunt. So with the help of endoscopy, the chances of revision rate of VP shunt reduces from 2.9, that is 3%, 3 per year, to 0.2 per year. So significant reduction of revision rate of VP shunt can be done. And if you are expert enough, then very rarely, in about 10 to 20% of cases, you can do also ETV after breaking the septa, but it is technically very demanding. In slit ventricle syndrome, there can be three things which you can do, because the ventricles are small, so it's very difficult to hit the ventricle. So one option is that the small flexible scope can be passed along the shunt tube, and then you can do ETV, or you can hit the ventricle using stereotactic guidance or USG guidance and use small scope and do the ETV. The other option is that you can the distal end of the VP shunt can be exteriorized, and you can block it, and then you allow the ventricle to dilate and then do the ETV. There are situations we have come across we have exteriorized the distal end, and then there were situations in which there was no ventriculomegaly and patient did not complain of raised ICP or headache. So in such situation, you can just observe. There is no need to do ETV, but if you exteriorize and after that, if you find that there is a ventricular dilatation or patient has symptoms of raised ICP or headache, in such situation, you have to do ETV. When you have a intraventricular hemorrhage with hydrocephalus, again, there are 3 treatment options. You can go for external ventricular drainage and remove the hematoma, but most of the time the catheter blocks, or you can go for thrombolysis. Again, the chances of infection in both these situations are high, and there is a catheter blockage. The other option is endoscopic removal of hematoma with or without ETV. It has a significant role in IVH with the hydrocephalus. In NPH, the role of ETV is there, but only in selected cases when there is floor of third ventricle is bulging down and the anterior wall of third ventricle is bulging anteriorly. So that means there is some component of obstruction, and in this subgroup, ETV is quite helpful. If you don't come across these situations, then you can go for the other 2 options, either a lumboperitoneal shunt or a VP shunt. You should be aware that in ETV, there are difficult situations. I told you that ETV can be done when there is a posterior fossa tumor, whether it is CP angle tumor or the midline posterior fossa tumor. So obviously the ETV can be done, but it is not for the beginner. You can realize that when there is a tumor in the posterior fossa, it pushes the brainstem anteriorly, so there is hardly any space between the clivus and the brainstem. So to do ETV is technically very difficult, and at times the brainstem bulges superiorly in the third ventricle. So there is a high sloping floor of third ventricle, which makes ETV difficult for the beginner. So in such situation, it is better to do third ventriculostomy on the clivus or on the dorsum celli. And if you have a CP angle tumor, in such cases, apart from pushing of the brainstem anteriorly, you also have displacement of the midline structures. So the ETV has to be done a little away from the actual midline in such patient, and you should make sure that you don't injure the third cranial nerve or the posterior communicating artery. So be careful, and only when you visualize the structures, you should do these ETV. And in cases where there is infection, there's a lot of exudate in the acute phase of meningitis, then also you should try and avoid the ETV. The usual ETV site, that is the floor of third ventricle. So in such case, you can go for ETV either anteriorly in the third ventricle, that is lamina terminalis, or posteriorly in the quadrigeminal cistern. So if at all you have to do ETV, then you have to choose the alternate site. Now, it is very important to know which cases are suitable for ETV, at least for the beginner. So in pre-operative workup, you should know which are the cases which are the good candidate. So there should be sufficiently large lateral ventricle. The foramen Monro also should be large so as to so that it can accommodate the endoscopic set, and the third ventricle also should width should be enough so that your endoscope can be accommodated there. If you have a large intrathalamic adhesions which can occur in spinal dysraphism cases, then it may be technically difficult. So you should make sure that there is no large intrathalamic adhesions when you do ETV, at least in the beginning of your learning curve. The third ventricle floor should be thin. If it is a thick third ventricle floor, then it is difficult to visualize the structures in the floor, especially the vessel, basilar artery, and there are high chances of complications. So avoid thick third ventricle floor in the beginning. There should be good pre-pontine space. There should be sufficient space between the basilar artery and the dorsum celli, and you should not have a very high riding basilar artery. If you have a high riding basilar artery, it pushes the floor of third ventricle up, and the floor of the third ventricle is sloping. So if you try to perforate the floor anterior to the basilar artery, your catheter slips. So you have to use other things like bipolar forceps or the blunt instrument, or perforate on the dorsum celli. There should be absence of basal exudate. I have said that if the exudates are there, even if you make the opening in the floor, it doesn't work. So failure rate is high when you have basal exudate. There should not be any abnormal vessel below the third ventricle floor. If it is there, then you should know beforehand, before surgery, and you should avoid injury to that vessel and prevent bleeding. There is sufficient distance between the midline and the posterior communicating artery. I told you that in CP angle tumor, there is distortion of midline, and in such case, because the midline is distorted, you tend to make the ETV little laterally, so there are chances of injuring that artery, which you should always be watching when you do ETV. Knowledge of anatomy, whether there is any additional membrane below the floor of third ventricle or any other membrane, also should be known when you do ETV. The other factors which you preoperatively you should investigate is that the distal CSF pathway beyond the basal cistern. So not only that the basal cistern should be patent, but the distal pathway also should be patent, and there should be good CSF absorption, which is sometimes quite difficult to know. But if you go for early stroke volume in cinephase contrast MR, if you have a good stroke volume, that shows that the basal cisterns are patent and there's a good CSF absorption. In such case, you can do ETV very well, and the success rate is likely to be high. And in some suspicious cases, you can also find out the lumbar outflow resistance and the ventricle outflow resistance. If there is a low ventricular outflow resistance or low lumbar outflow resistance, that means the subarachnoid space and the cisterns are patent, and the absorption also at the arachnoid villi level is also patent. Then only you will have this. But on the other hand, if you have a high outflow resistance, that does not mean that ETV is not going to help. It may be because of the CSF obstruction because of the ventricular dilatation. Ventricular dilatation may obstruct the subarachnoid space, and therefore there may be high outflow resistance. So if there is a low outflow resistance, it is a favorable, but high outflow resistance does not rule out that ETV will not be functioning. In the surgical technique, the supine position is used. Some author use semi-sitting position, and the head should be a little flexed so that the burr hole is at the highest point. Otherwise, there may be entry of air, especially when there is a high ventriculomegaly. The burr hole side depends on the individual anatomy, and not that you should make a burr hole 1 centimeter anterior to the coronal suture or 2 centimeter or 1.5 centimeter or something like that. So these are individualized, and this is the most important factor for successful ETV, and that you should determine by the individual anatomy or by navigation. So what I do is that you can mark foramen Monro using a CT or MRI if you don't have navigation. If you have navigation, it is fine. So you mark the midline, and you mark the coronal suture, and you should go towards the external auditory matters. About 6 centimeter at depth is the foramen Monro, but it depending upon the ventricular dilatation, whether it is less or more, this site may change. So you should exactly land on the foramen Monro. So it is better that you know it either by navigation or by using CT or MRI, and use marker on MRI or CT to delineate where the foramen Monro is there, and which is most important point in your surgery. The penetration, when you make burr hole about 2 to 3 centimeter away from midline, it should be medially, and it should be directing towards the external auditory matters when the navigation facility is not available. You can use different kind of sets where there is endoscope in the sheath inbuilt, and there are irrigation channel and outflow channel, the endoscope and the working channel. So various sets can be used. Regarding the trocar, it is better to have trocar with hole. So if you have a trocar with hole, it allows you to know that you have hit the ventricle. If it is not there, then you might face some difficulties. I have already said that it is important to know the proper site of the burr hole. So exact site of the burr hole in coronal plane and in sagittal plane is essential. So how to decide the exact site of the burr hole? And I told you that it should be individualized. You cannot say that it is 1 centimeter anterior or 2 centimeter or 1.5 centimeter. So you have a MRI, then you should identify the prepontine cistern, and the line should extend from prepontine cistern to the foramen Monro onto the skull. So this line, so the site of burr hole should be here. The line connecting the prepontine cistern to the foramen Monro to the skull. And you can measure the distance from the bull. Likewise, in the coronal plane also, you should start the line joining the midline of the third ventricle. floor to the foramen Monro onto the skull. So the distance from midline to the skull side should be the site of the burr hole. But usually, even if you remain as medial as possible, that is 2 to 3 centimeters away from the midline, is all right. But for sagittal plane, it is important to draw that line or to have navigation, and you should land directly on foramen Monro, and you should land directly on the translucent place in the floor of third ventricle, which is anterior to the mammillary bodies and in between these mammillary bodies and infundibular recess, which I'll discuss. So if there is a wrong site of burr hole or trajectory, then you predispose, there will be fornix injury, and there may be bleeding also. So that should be avoided. So you should have a correct site of the burr hole, and you should also have a correct trajectory. So you can have correct burr hole. See in this diagram, please pay attention that the burr hole site is all right. You can make a burr hole at this place, and you land at the foramen Monro, and then you make the opening in the floor of third ventricle. So the green line is a correct burr hole site and the trajectory. The other red and blue line, the burr hole site is correct, but the trajectory is wrong. So if I make trajectory more posteriorly, then I'll not be landing on to the foramen Monro, and I'll be much more posteriorly in the lateral ventricle. And in trying to reach the foramen Monro, because I have to go through the foramen Monro into the third ventricle, then I'll be moving my endoscope anteriorly, and in the process I'll be tearing the ependymal lining and the cortex. And same is true when you are too much anteriorly there. So there should be a correct burr hole site, and there should be correct trajectory in the coronal and sagittal plane. The other thing which I want to stress is that in coronal plane also, if you have a correct burr hole site, and then you go through the foramen Monro and go in the third ventricle, this is the green line is a correct site. But if you are too much medially placed and you go, there are situations where the septum pellucidum is absent in a long-standing hydrocephalus. So if you enter wrongly in the opposite side of the lateral ventricle and through the opposite foramen Monro, you go in the lateral third ventricle, and then you try to bring your scope in the midline. In the process, you will injure the opposite side fornix and also the ipsilateral fornix. So this should never ever be done. So it is important to have correct site of the burr hole and the correct trajectory in both coronal and sagittal plane. So how to make the proper burr hole? I said that if you have facility of navigation, it is better. But even if you don't have, then you can mark the foramen Monro using CT scan, a marker CT or marker MRI, and then you can place some marker like Evion capsule or something on the skin and make out that this is foramen Monro. Although by anatomical landmark also you can go there only. So the direction of the trajectory should be towards the external auditory meatus in sagittal plane, and it should be slightly medial in the coronal plane. In that case, you will reach at the foramen Monro. But if you are away from the foramen Monro, it is better to abandon that trajectory and take another trajectory. So burr hole should be at the highest point. Usually it is on the right side, Am I audible? It is coming as internet connection is unstable or something like that.
Oh, yes,
Hello?
you are audible.
Yes, sir. Audible, sir.
You are
Okay.
audible, sir.
Okay, okay. Thank you. It is usually on the right side, but there are situations in which you can go from the other side, that is left side, when there is asymmetrical hydrocephalus. So in that case, the one ventricle, lateral ventricle is large, the other is small. So if you have asymmetrical, then you should go from the less dilated ventricle side rather than more dilated, because more dilated ventricle is likely to have obstruction at the foramen Monro, and perforation of the septum pellucidum from more dilated side will be difficult. So you can go from the less dilated side, you can perforate the septum pellucidum, and you can do ETV, because that foramen Monro is likely to be patent on that side. The blind insertion should not be beyond 5 to 6 centimeter from the burr side. Avoid over drainage of the CSF. Prevent entry of the air in the lateral ventricle or in the subdural space. That will not allow good visualization, and do not allow loss of CSF. Otherwise, there may be subdural hematoma. Use brain cannula. I have seen people directly entering the ventricle by the sheath, whether it is GAP sheath or the lotus sheath or any other sheath. So it is better to use ventricular cannula, hit the ventricle, and then use either peel away sheath or use the endoscopic sheath. This using sheath is important, because otherwise you might need repeated introduction of your scope, and that sheath should be slightly larger than the endoscope, so that the fluid can freely come out when you go for irrigation. So you can use freehand technique. That means you don't use any endoscopic holder, or you can use holder. I use holder, but I don't lock it. So I keep this unlocked so that I can move my endoscope freely. So I hold the left hand is used for holding the scope. The right hand is used for introduction of the instrument. Telescope holder is used with the loose knob, so but it is attached to the endoscopic arm, and the assistant is holding the arm. If they don't hold the arm and it is loose, then it tends to fall, and you have more strain on your left hand by which you are holding the scope. So ask your assistant to support the arm of the endoscope, so there is no time wastage in locking and unlocking, and you can make little bit of movement. So the question is, why holder at all? Because the procedure is very short, so you can do it freehand, but there are situations in which there may be bleeding during ETV. So in such case, if you don't use holder and you have to hold it for a quite long time, there may be fatigue. So in such case, you can use holder, and you can station your endoscope in the lateral ventricle and hold on for some time till the bleeding stops. So I use holder, but I keep it loose, and I support my hand. Through the right hand, I introduce my instrument, forceps or anything, ventricular forceps or bipolar forceps, but I support my hand on the sheath of the endoscope, so that there is no additional tremor or any unwanted movement. There is good precision movement there. Regarding the use of fluid, I use lactated solution as compared to normal saline, because the pH and the osmolarity of ringer lactate solution is near the CSF, and therefore that should be used. A word about dark ventricle syndrome. There are situations when there is a huge ventriculomegaly, large ventricle in an infant. So you go in the lateral ventricle and nothing is visualized, everything is dark. So this is because the ventricles are large and the focal length of the endoscope is small. So the structures in the floor of the lateral ventricles are not visualized. So gradually move your endoscope deeper in the ventricles, and when the structures in the floor of third ventricle will come in the focal length of the endoscope, then it will start visualizing. So don't worry if you don't see anything, then gradually go inside because the ventricle is large and this is beyond the focal length of your endoscope. Therefore, you are not able to see anything. If you don't see anything, the other, if it is just a white thing, then it may be because of the infection also. So in that case, irrigate, and gradually the things will clear. If you are there at a wrong place in the lateral ventricle, so these are the two examples. This is a proper burr hole and the trajectory. You should land on the foramen of Monro in the lateral ventricle. So that is correct trajectory. But if you go more posteriorly or more anteriorly by making a wrong side burr hole or wrong trajectory, then it is better to abandon that trajectory rather than moving your endoscope posteriorly or anteriorly and tearing the ependymal margins and the brain. So avoid that, abandon that trajectory and go at a correct site. And same way, if you go more posteriorly in the third ventricle or more anteriorly in the third ventricle, you should land at a translucent place in the third ventricle in between the mammillary bodies and infundibular recess in the midline, in the translucent place when you use rigid scope. But if you are away from there, then don't move your endoscope too much. If you move your endoscope anteriorly or posteriorly, and if the foramen Monro is small, then you will injure the fornix. So if there is a wrong burr hole site or a trajectory, in that case, abandon that trajectory and come again choosing a right trajectory. And I have already discussed that if your burr hole site is too much away from the midline, and then you try to enter into the through the foramen Monro into the lateral ventricle, and then you come in the midline. If you are too much lateral going through the foramen Monro, then you will be landing on the opposite side of the third ventricle, not exactly in the midline. And if you move your scope to reach at the midline, then you will injure the ipsilateral fornix. But if you make too much of mistake, you go on to the opposite side fornix using a rigid endoscope, and then going very much laterally in the third ventricle, and then trying to come at the midline. In the process, you will injure both the fornix. So that should never ever be done. If you come across a situation in which you have to do septum pellucidum perforation and ETV, in such cases, the trajectory for ETV will be different and the trajectory for septum pellucidum is different. But using a same burr hole or trajectory, you can do both ETV and septum pellucidum perforation. For that, you should have the single opening forceps as shown here. Sorry, somebody is knocking. Mat aao bhai. Arey chhod yaar. So the forceps which is opening on one side should be use the forceps which opens on one side rather than a forceps in which both the limbs are opening. So this will make the septum pellucidum perforation difficult. Whereas if one limb is opening, you keep that limb on towards the septum pellucidum and perforate the septum pellucidum. So both ETV and septum pellucidum perforation can be done. Regarding the fenestration in the third ventricle floor, Foreman Monroe can be identified by the confluence of thalmostriate vein, the septal vein, and the choroid plexus. So this is the choroid plexus, this is the septal vein, and usually there is a thalmostriate vein going like this. But in this case, it is not visible. The fenestration in the third ventricle floor should be in between the mammillary bodies and the infundibular recess at the most transparent site in the midline, and it should always be anterior to the basilar artery. Even if there is a translucent space posterior to the basilar artery, you should never ever do a perforation posterior to this, because there are perforator going from basilar artery to the brainstem, and if you make fenestration there, you are likely to injure those brainstem perforators. So never posterior to the artery. The location of the basilar artery should be identified. If it is a translucent third ventricle floor, then you can visualize during endoscopy. But if it is thick, then you should identify with the vascular Doppler or navigation, or make the third ventriculostomy on the dorsum celli. So do not perforate posterior to the dorsum celli, because you don't know where the artery is lying. So make the perforation on the dorsum celli if it is thick wall. And the other things I'll discuss. So perforate on the dorsum celli if there is a less space between the basilar artery and the dorsum celli. There may be situations when there are posterior fossa tumor, when brainstem has been pushed anteriorly, so basilar artery also has been pushed anteriorly. So in that case, if you make perforation posterior to the dorsum celli, you may injure the basilar artery. So if such situations are there, you should anticipate that, and you make perforation on the dorsum celli. Just use the forceps and catch the membrane there, and just rotate it and tear it. So tear the floor, and then the CSF will percolate from the third ventricle into the prepontine cistern, and you will find some space between the dorsum celli and the artery. So perforate on the dorsum celli if it is the basilar artery is pushed anteriorly, or when you have a thick floor. Why in the thick floor? When there is a thick floor and if you try to perforate posterior to the dorsum celli, you push the floor of third ventricle too much because it is thick. So there is a tendency to displace the floor of third ventricle. So there is a possibility of bleeding from other side because of too much of displacement of the floor of third ventricle. And at times the third cranial nerve is attached to the Lilliquist membrane or the other membrane in the floor. So that also gets stretched and you can produce third cranial nerve palsy. So do not perforate posterior to the dorsum celli when the basilar artery is pushed anterior, or when there is a thick floor and there is a displacement when you use blunt perforation. When you have thick and inflamed floor of third ventricle, you can use water jet dissection, which I described in one of my articles, especially in TBM. You can start the dissection with the blunt forceps, but with using the indigenous water jet dissection using the infant feeding tube or any other tube just near the opening at the floor, and then you inject about 10 ml of fluid in about 3 to 5 second time using a syringe of 10 ml. That prevents bleeding and it allows opening of the third ventricle floor. If you don't see, there are technical nuances. When you do third ventriculostomy and the jaw of the ventriculostomy forceps is not visualized, then these are the three causes. Either there is too much magnification, you have used too much of zoom button, so therefore the jaw of the ventriculostomy forceps are out of the field of your endoscope, or you have gone too much close to the surgical target area. In that case also there is high magnification and the jaws of the ventriculostomy forceps are out of the endoscopic field. So in that case, de-zoom it. In this case, when there's a high, or go away from the floor of third ventricle and you will start visualizing both the ventriculostomy forceps, because you should never ever do anything blindly in ETV. It should be all under vision. The other possibility is when the endoscope and both jaws of your ventriculostomy forceps are in the straight line. So if this is the endoscope, this is one jaw of the ventriculostomy forceps, this is another jaw of the ventriculostomy forceps, the distal jaw will not be visualized. So move your scope little bit laterally or rotate your the ventriculostomy forceps little bit, both jaws will be visualized, and then only you open your ventriculostomy forceps. So never ever do anything blindly. This is my technique of making a opening more than 5 millimeter, because third ventriculostomy opening should be 5 millimeter or more. So at times I make 2 openings just off the midline. Usually you should make the third ventricle opening in the midline, but I make opening just off the midline, but not as little as to injure the third cranial nerve. So not so much lateral, but just off midline, 2 to 3 millimeter off midline. I make these 2 openings and then I join these 2 openings, and this is how I make the large opening, which I think, although not proved, but it is helpful in avoiding stoma blockage post-operatively. A word about the Lilly-Kist membrane. We all know that there are 3 divisions: cellular component, diacephalic component, and mesencephalic component. So if you do third ventriculostomy a little more posteriorly, then you might come across 2 membranes. There will be one membrane that is diencephalic component of the Lilly-Kist membrane, and another component that is mesencephalic. So you might have to rupture 2 membrane. But if you are little more anteriorly, then there will be only 1 membrane. So all the membrane, whatever you come across in the floor of third ventricle should be fenestrated, and you should be able to see the naked basilar artery. The third cranial nerve injury can also happen when there's a thick floor of third ventricle and when the Lilly-Kist membrane is attached to the third cranial nerve. So if there is a thick, Lilly-Kist membrane which is attached to the third cranial nerve laterally, and if there is a thick floor and you just push it by the blunt forceps, and it displaces the floor along with the third cranial nerve. So already stressed third cranial nerve may get further damage, and you can produce third cranial nerve palsy. So never ever try to forcefully make an opening in the thick third ventricle floor with the blunt instrument. In that case, you can use low current bipolar current at a low setting, and then try to make opening, and do not displace it too much down. This may cause third cranial nerve palsy. So if there is a thin floor of third ventricle, then you use blunt perforation. This is the best thing. But if it is thick floor, then initially I use short low bipolar current, so that I can start blunt perforation in the floor to avoid displacement of the third ventricle floor. Usually we avoid energy, that is any bipolar or monopolar current in the floor. But people have used laser assisted third ventriculostomy, which they found to be safe and effective, can be used in thick floor. Dilatation of the stoma should be minimum 5 millimeter or more, and you can use either a Fogarty catheter for dilatation, or you can use ventriculostomy forceps for dilatation. If you want to do ETV and biopsy, I have already discussed that either you can use two burr hole, one for ETV and one for biopsy. If the foramen Monro is small, or one burr hole when the foramen Monro is large, somewhere in between. So ETV burr hole and a biopsy burr hole, you can make burr hole somewhere in between when the foramen Monro is small, and you can rotate your working channel from anteriorly for ETV to posteriorly for biopsy. And or else you use flexible scope. Avoid linear movement. If at all you have to use some movement, then you should not exceed a slow movement of 5 millimeter. This has been seen by Zhu et al. That slow movement of 5 millimeter can be tolerated by the fornix without any injury. But if you have to make some movement, then you can rotate your scope, and by rotating the scope, if the working channel is anteriorly placed, if you rotate it to the 180 degree, then your working channel will come posteriorly, and you can buy about 5 millimeter minimum, 5 to 6 millimeter by just rotation, not by linear movement. So you can rotate the endoscope. The third option is that you keep your endoscope in the lateral ventricle near the foramen Monro, and then you pass the thin instrument through the foramen Monro under vision. So you know that the forceps is going through the foramen Monro, and how much is it is causing the distortion of the foramen Monro. Then this is not a blind procedure. So this is the third option which can be utilized. Inflate Fogarty or ventriculostomy forceps at the stoma. Do not inflate it below the stoma and then pull it back. If you do it, then you can catch any of the perforator and can cause injury. So inflate the ventriculostomy forceps or Fogarty at the stoma and not below the stoma, because there you can have vessels. If there is any doubt about the ETV functioning, I told you that when you do ETV, and if you find that the floor of third ventricle is pulsating well, that is a sign of good ETV functioning, and all membranes have been opened. But if there is any doubt about the third ventriculostomy functioning, in that case you can put in dye. The ioxol can be used 6 cc in adult and 3 cc in children. and you put the dye in the third ventricle. If the dye washes out in less than 1 minute, it is a good washout. That means your ETV will function very well. The basal cisterns are okay. But if the dye stays in between 1 to 3 minutes, then it is a fair, basal cistern, and then these patients may have problem post-operatively. So it is better to put in either Omaha reservoir there. And if the dye stays more prolonged, more than 3 minutes, then this ETV is not likely to function. You should take perioperative decision to do shunt in these cases. So there can be 2 situations during surgery, 3 situations. There may be favorable anatomy, good pulsations of the stoma, and there is a good cistern, and the flow of the dye is also good. It washes away within less than a minute, and you come across a folding sign. That means the posterior wall of third ventricle shows some folding. That shows that there has been a good outflow. So such cases are likely to do well. But if there is a doubtful cases, stoma pulsations are not good, the dye holds on for 1 to 3 minutes, the cisterns are scarred, in such case, you use Omaha reservoir. I have seen people who recommend put in reservoir always. So it should never be always a reservoir or no reservoir. There are definite indications. The perioperatively you can make decision that this patient is likely to do well. These patients are likely, these are doubtful cases. You can put in Omaha reservoir and tap the CSF post-operatively for 10 to 15 days, and then you may find that gradually the subarachnoid space may open up. There may be poor risk cases of ETV where intraoperatively either it is technically difficult, the floor of third ventricle is not visible, it is all red. So in that case, it is better to abandon the ETV and go for a shunt. Or there is a bad cistern, or there is a poor flow, the dye stays for more than 3 minutes. In that case, you go for perioperative decision that this ETV is not likely to function, and do go for a shunt perioperative. This is what folding sign has been described. After doing a ETV, if all membranes are open, then you might find some folding in the posterior wall of third ventricle, and this denotes that all the membranes have been opened up. And if you find this folding sign, although it is not always seen, but if it is there, then it is a good sign of ETV functioning. So indication of Omaha reservoir or EVD, I have already discussed in cisternal scarring. If there is a poor stoma pulsation, if there is a fair flow, that means the dye holds for some time in subacute phase in the infective or post-hemorrhagic cases, or there are multiple shunt failure. In such cases, usually the subarachnoid spaces are collapsed, and it takes some time to open up this subarachnoid space. So if you keep the Omaha reservoir for some time and draw fluid post-operatively, then it allows time for the subarachnoid space to open up, and your ETV will start functioning. So this Omaha reservoir can elevate, can decrease the raise ICP if it occurs post-operatively after ETV, and it allows quick access to the ventricle, and you can put in dye or see whether your ventriculostomy is functioning or not. Post-operative care is also very important. If the patient after ETV does not improve, then there can be problems. There can be blocked stoma. There can be complex hydrocephalus. There can be cerebral ischemia, especially in TBM. There may be associated ischemia. And if there is a ischemia associated with hydrocephalus, these patients do not improve so well after surgery. So you are in doubt whether your ETV is functioning or not. So these are the various causes. Or pre-operative neurological status. The patient is already in bad GCS. So in such case, you should find out whether there is raised ICP or not. If it is raised ICP, then usually it is either because of blocked stoma. In such case, repeat ETV should be done, or there may be complex hydrocephalus. That means there is absorption. So if it is a temporary defect in the absorption of the CSF because of the collapse subarachnoid space after the shunt, in that case you go for repeated LPs for 10 to 15 days in every 3 to 4 days time. Allow the subarachnoid space to open up, and these patients do well, some of them. But if they continue to have raised ICP, that means there is a permanent defect in the CSF dynamics. And in such case, you have to use either a VP shunt or a LP shunt. But if there is a no raised ICP after ETV and patient does not improve, that means the cause of failure to improve after ETV is either because of ischemia or poor neurological status before surgery. So what does repeated LP does? It increases compliance and other things. So one should go for 1 to 3 lumbar puncture at the interval of 3 to 4 days before you call that ETV is a failure. The failure of ETV usually occurs within 3 months. So you require a good clinical and radiological assessment. But it has been seen that the radiological assessment is not as important as clinical. If you go for radiological assessment, then you may overdo either a ETV, repeat ETV or shunt. So if both, if there is a failure to improve along with some radiological assessment showing that the third ventricle dimensions have not decreased, in that case you can consider that it may be a failed ETV. I think one can use conventional MRI, but it is an indirect sign. Resolution of periventricular edema, widening of the subarachnoid space, these are indirect signs. A diminution of the third ventricle size, if it occurs, that shows that your ETV is functioning. The third ventricle dimensions are more important than the lateral ventricle. So if the height of the third ventricle decreases or the infundibulochiasmatic angle also is reduced after ETV, that means ETV is functioning well. The flow void sign is not that sensitive. There are limitations, but cine phase contrast MRI is more sensitive than this, which I can skip. But if there is a high suspicion or you don't have good cine phase contrast MRI at your center, then you can use CT or MR ventriculography. You can put in dye in the ventricle, and if the dye is not coming in the subarachnoid space, that means the stoma is blocked. But if the dye is coming in the basal cistern, but your patient is not improving, that means it is a complex hydrocephalus. There is a defect in the absorption, and such patient, if there is a permanent defect in the absorption, then you go for LP shunt or VP shunt. The ETV and telemetric ICP monitoring can be done because we know in certain percentage of patient, there is a persistent raised ICP after ETV. In TBM hydrocephalus, there can be three situations. There may be communicating hydrocephalus in which I do LP shunt, lumbar peritoneal shunt. If there is a obstructive hydrocephalus in chronic phase after 3 weeks of diagnosis of TBM, and you have given ATT, in that case, if you do ETV, it is likely to work. But if it is acute phase of infective hydrocephalus, then ETV usually doesn't work. So I prefer VP shunt in such cases. Complications can be temporary or permanent fever, bleeding, hemiparesis, gaze palsy, persistent subdural collection, and the memory disorder, altered sensorium, diabetes insipidus, or weight gain or precocious puberty. A word about secondary ETV. This could be when the ETV fails. So re-ETV is also known as secondary ETV. Or if you do ETV after shunt malfunction, that is also done and known as re-ETV. So secondary ETV after post-traumatic or post-meningitis or after the congenital malformation has high success rate than the primary ETV. So because the acute phase is over, so the secondary ETV in these situations have a higher success rate than the primary ETV. If there is a previously shunted patient, then it is better to remove the shunt if you can easily remove it. But if it is densely adherent, and then it is better to leave it there, but you can block the shunt. I think I'll not go into the ETV because time is already, we all know how to do this ETV. The type of floor can be transparent, can be opaque, and can be very opaque. So this translucent third ventricle is good, and these cases are difficult to do ETV. And if it is very opaque and you don't see any structures there, it is better to abandon the ETV. A word about choroid plexus coagulation. It is useful in infantile hydrocephalus, and especially when it is associated with the spinal dysraphism like myelomeningocele and spina bifida. So if you combine ETV and choroid plexus coagulation in infant associated with the congenital spinal dysraphism, the success rate has been found to be more. And also in post-infective and post-hemorrhagic hydrocephalus, and in infants where there's a very low cortical mantle, means there is a huge ventriculomegaly in infants. So in such case, if you do ETV along with the choroid plexus coagulation, the results have been shown to be better, and in dandivocal malformation. If there's a bleeding, when you do ETV, reinflate the balloon or gently put in the ventriculostomy forceps at the place where it is oozing. So for some time, then it stops, and you go for copious warm fluid irrigation, and usually small bleed stops. You can intermittently close the outflow channel and create the tamponade effect, and the bleeding usually stops if it is oozing. Tamponade is better than taking out the instrument. If you are using a ventriculostomy forceps or any blunt instrument, don't try to take it out and then try to bring in the bipolar forceps. By the time you bring in your bipolar forceps, it will be all red. So it is important to either reinflate the Fogarty or put in the forceps, blunt forceps on the bleeding side, and keep it for some time, usually the small ooze stops. And the other trick is that they say that create a large cavity, that is large ventricle into the small cavity. So withdraw your telescope away from the sheath. So create a small cavity where there is a translucent fluid, irrigating fluid, which allows visualization of the bleeding point. And then you can just put your sheath on the bleeding point, and you can see the bleeding point, and maybe you can use bipolar and close it. I mean, coagulate it. The air media, if nothing works, then you remove the fluid. Visualizing the bleeding point in the fluid media is very difficult, but under the air media you can visualize the bleeding point very well. So take out the fluid, put in equal amount of the air and replace the fluid with the air, and you will visualize the bleeding point, coagulate it. And if nothing works, then you can use tubular retractor under endoscope and stop the bleeding. The alternate site of ETV can be subfrontal approach, and you can fenestrate the lamina terminalis, especially in TBM where the floor of third ventricle is very thick and it is not suitable. Or you can go transventricular and fenestrate the lamina terminalis, or you can open the quadrigeminal cistern. So these are the alternate site. Or from the temporal horn, you can open into the suprasellar or perimesencephalic cistern. So these are some of the alternate site if there is a unilateral hydrocephalus or the usual site is not suitable. Regarding the ETV and AS, success of ETV in children was poor compared to adult in some series. Kulkarni et al. Found that there is a relatively high risk of ETV failure in patient less than 6 months, but later on the relative risk becomes progressively lower after 3 months. We found, and some other people also found, that ETV is not dependent on age. So we do it even in the infant, but what is more important is the success is poor when the infant is premature or it is associated with post-hemorrhagic hydrocephalus. So here you see that the ETV success score depends on the age. Lesser the age, there are less chances of success. Etiology, post-infective, and in congenital defect or post-hemorrhagic, also there are less chances of success. And if there is a previous shunt, then because of the collapse subarachnoid space, the success may be poor, but we did not come across this particular finding. So Kulkarni et al. Has found that if the score is 60 to 70, then the ETV success rate is likely to be good. But if it is less, then it is likely to cause failure. I think I have already over exceeded, so I don't want to summarize the same thing which I have repeated. So I close it here. Thank you very much. So I have not discussed the complications. It is a separate talk, but I think I have already discussed how to avoid complication and how to treat these complications. I have already discussed it in one of my articles, rather several of my articles in Neurology India and other journals. Thank you very much.
Very good.
Thank you,
Dr.
sir.
Swami, go ahead.
Thank you, sir. Thank you. It was again as extensive as what you usually teach. Every possible complication, indication.
Sorry for such a long talk, but I think all these things were important for the beginner.
Yes, sir. Yes, sir. I think even from beginner, I think this has been like in reading a whole textbook within around 1.5 hours. You have discussed extensively, sir, and we are fortunate enough to have senior panelist Dr. Hemant Bharatia, who has trained himself in US as well as a Fujita fellow, and Dr. Rishim Kataria, Professor Rishim Kataria, who is in SMS teaching all the undergraduate MCH residents as well as a very enthusiastic endoscopic surgeon. We have Professor Ramesh Tigala, again, very well-known endoscopic endoscopist, neurosurgery. Sir, I don't see any questions being put up in this particular thing. So I'll welcome the panelists to take on something and then discuss.
Let me start with, of course, Professor Yadav, wonderful presentation. You have covered everything. So that's great. That shows the rich experience of a surgeon. So your experience that you have presented, in fact, small points. What I would like to emphasize is that for the younger neurosurgeons who are starting the ventriculostomy in at least moderately dilated ventricles or large ventricles is number one. And it is difficult for them to rotate the scope, not to try to rotate the scope for the biopsy in the beginning. Once you are experienced, you have the experience of holding the scope and putting in the instruments. When you are confident of doing it, then one can attempt, because I am still afraid of rotating the instrument in 180 degrees to take the biopsy or doing something. And the second point is about split ventricles.
I answer before I forget? I'm an old man. So
you are younger than me.
I mean, the thing is that you should never ever do it in the third ventricle. If you rotate it, you might injure the fornix. So bring out your endoscope in the lateral ventricle where there is more space, and then you rotate and go inside the third ventricle. You are absolutely right, sir. Thank you.
Another point was about the slit ventricle, where you said that you can use either a flexible scope or you can use navigation, or the third point, either you exteriorize and block the shunt and let the ventricle dilate, and then you do the ETV. I would like to know your experience with the flexible scope or doing ventriculostomy in slit ventricle with navigation. You have, or you are doing only exteriorizing and blocking and then doing a shunt, or you are changing the shunt to programmable shunt, or changing the valve or the ventricular catheter in slit ventricular syndrome. Sir, what is your experience?
Oh, you are absolutely right, sir. I have, although we have the flexible scope, I think we missed Dr. Subodh Raju. He has experience. I have not used it. I said there are three options. When I come across these situations, then I try and exteriorize the distal end, and then try to get the ventricle dilatation. But that must be done very carefully. These patients may deteriorate quite fast. So you should tell your resident that if something happens very suddenly, then you have to open the exteriorized block distal end. So I have done it in one case, exteriorize it and then block the distal end, and then allowed the dilatation of the ventricle and did ETV.
Before I give it to the other panelist, I would share my experience that in CP Engel or in the acoustic neuroma, where I used to do ETV, but the success rate was not very encouraging. So I gave up that, and we usually treat them directly by the excision of the tumor, number one. The other point is that in the slit ventricle itself, you said when you are exteriorizing, the second point you made, when there is no ventriculomegaly, no raised ICP or no headache, then observation. Then why did you do the imaging, or what was the need of doing anything? If there were no symptoms, then what was the need? This was I don't know.
No,
Maybe.
sir. When patient had slit ventricle syndrome, that means they usually have intermittent symptoms. So if
intermittent headache.
Symptoms, intermittent, there is a dilatation and this thing. So in such case, the policy is that you exteriorize it, and then even after exteriorization, if the patient do not have the symptoms of raised ICP, or there is no progressive dilatation of the ventricle, you can just hold on and observe this. If they have ventricular dilatation and the patient has symptoms of raised ICP, headache and other symptoms, then you need to treat them. So there is a very small subgroup, about 10 to 20% or something like that. Those patients do not have anything. So
in the
just
trajectory,
them along.
in the trajectory point also, you said that towards the external auditory meatus or the canal. Usually, I don't know, I am learning this from you, that because we have been doing it towards the nasion or the canthus of the eye, the scope also goes in that direction. So this is something new which I have learned, that going towards the external canal would be going laterally towards from the burrow.
Sir, this is a mistake. Going towards the external canal in the sagittal direction, but also going medially. You cannot go laterally, you will not hit the ventricle. So in sagittal plane, see in the sagittal plane, if you can see my head, I can go more anteriorly, I can go towards the external auditory meatus, but angled medially. You cannot angle it towards the external auditory. In the sagittal plane, you should go towards the external auditory meatus.
Thank you. I'll let the other panelists also have their views.
What I meant is the three-directional, the three-directional axis.
He
in
showed
coronal
that
plane, you have to go medially. You have to go medially, yeah.
So before I pass on to the other panelists, the questions have come up. I think we should answer and then go to the panelists, because Dr. John has been asking, do you have advices for hemostasis and bleeding control with endoscopy technique alone?
Do you
have the advice for hemostasis and bleeding control just with endoscope? I think you already elaborated on it, how exactly what the bleeding occurs. Try and put, increase the irrigation, and then mostly it stops. In case if it doesn't stop, then see the bleeding point, replace the water media with the air media. Still, if it doesn't, then you use the tubular retractor. You covered this point. I hope Dr. John gets the answer, sir.
I think the other thing is that you should try and put if it is a Fogarty catheter, don't take it out. You just re-inflate it so it stops. If you are using a ventriculostomy forceps, you have dilated, and then you close the limb of the ventriculostomy forceps, re-inflate it, or put in that forceps on the bleeding point and it stops. If it doesn't stop, then you use intermittent blockage of the outflow, use tamponade effect, and keep irrigating, usually stops, and use air media and like that, which I have discussed.
So, and he also has second question. What's your policy for closure regarding to avoid the leakage, and the policy for the ETB failure? Institutional policy.
Yeah, so just for the sake of confidence, how much it works, I don't know. We usually put in the T-shape Abgel in the cortical site. So we just plug the cortical opening using a T-shape Abgel. T-shape, why? Because it should not, there have been some case report showing that the Abgel has floated in the ventricle and caused blockage of the third ventriculostomy. So this is one thing. And in infant, I try to close the dura if possible. This is another thing. Third very important thing, when there is a thin ventriculomegaly, there is very high risk of CSF leak. So don't remove the sutures early. I remove suture very late. So applying these technique, it works. If there is a leak, you should always suspect that there may be a blocked stoma. So always rule out blocked stoma if there is a leak, except in situation where there is a huge ventriculomegaly in infant, where CSF might leak even if the stoma is not blocked.
So the second question of him is the institutional policy if there's a ETV failure.
I go for, we go for investigation. If it is a blocked stoma, we go for re-ETV rather than putting in shunt. And I told you that before you call as a ETV failure, especially in infant and young children, we go for repeated LP shunt for 10 to 15 days. This duration, and we do it 3 to 4 times at the interval of 3 to 4 days. We come across usually when you do ETV in infant, after the ETV, the AF goes down. After 4 or 5 days, it bulges again. You do a lumbar puncture, it goes down. After some day, it again comes back. So before you call it as a ETV failure, you should go for 3 to 4 times lumbar puncture, and you buy some time for 10 to 15 days. By doing that, you increase your ETV success by at least 20 to 30% more.
Thank you,
and
sir.
Especially after the shunt. After the shunt also, that is secondary ETV, there is usually a collapsed subarachnoid space and it takes some time. So there is a persistent raised ICP. Either the patient will continue to have a headache, and you have, if you are impatient, then you go for shunt surgery and you say that it is a failed ETV. So before you call it as a failed ETV, you should give sufficient trial, but make sure that the stoma is functioning before you do repeated this thing. Or during surgery, if you have a suspicion and you have put in a Ommaya reservoir, then you can tap the CSF from there.
So Dr. Jeremy has a question, sir, which is though you're told about that folding sign, though it's not seen in all the patient, wonderful folding sign, you showed the picture also. He want to ask, is it a better sign or is empty basilar sign is a better sign?
The best sign is, see, I have not observed this, but I have taken all the review of literature. This has been described by someone, which they found it is quite effective in 70% cases. This has been reported in the literature, but I have not observed. We usually do not have that angled scope in our institution. But this has been described in the literature that if you find this is a good thing. The best sign during surgery is a flopping floor of the third ventricle. If you find that the floor of third ventricle is flopping, going up and down, it's an excellent sign that you have broken the floor, and also you have broken the Lilliquist membrane or any other membrane in the floor. So that is the best sign one can have during surgery.
So we will pass on this question to our two panelists, esteemed panelists. it's very difficult to establish the ETV failure as such, because patients are worried in the sense they come with large head, patients expect dramatic relief. So if I ask my panelists, expert panelists, when should you do the next CT to say that yes, it is reducing, or should we include just the head circumference? Or say, suppose if you do it in the later stage where there's a large head after 18 months, so what exactly is the thing? Should we go for MR studies, as Sir has said, that to find out the stoma, this thing, okay, or should you do ventriculography? Which would be better? Dr. Ramesh and Dr. Rasim?
I can take this question. Thank you very much.
Please.
Before I go in, I would like to personally congratulate Professor Yadav for excellent talk. It's like an encyclopedia of endoscopic third class literature. Regarding to your question, usually it depends on the clinical parameters. Like mostly kids, they have a bulging fontanelle when it is before 1.5 year time. The flat fontanelle is one sign of working ETV. Secondly, their nutrition improves. Their appetite, like usually most of the kids, because of the gross raised intrathecal pressure, their feeding is very poor. That is a common complaint from the mother side, actually. That's the one sign, and patients, babies, activity improves, actually. Their day-to-day activity improves. Those are the basic clinical signs which suggest that there is a functioning ETV, or there's no, at least drop in the ICP initially. Secondly, if you have a leak or if you have a tense fontanelle, then it's definitely requires to investigate at least with a basic CT to see is there any bleed inside the ventricular cavity because of the procedure, or there is a persistent PVL is seen. Then if that is observed, then we can go for at least MR CSF flow studies or some contrast dye studies to demonstrate is there any functional stoma is available or not. If that is not seen, then as Sir said, like we can attempt multiple lumbar punctures, which nowadays many people are not doing that one because of the non-invasive test. So if that is necessary, then we can do the multiple lumbar puncture techniques for 1 or 2 days and see how the baby reacts. If they don't respond, then based on the MRI findings, either you can try for a redo ETV or a shunt, whichever is feasible in the given circumstances, can be adopted based on the clinical radiological findings. That's what we routinely follow.
I think Dr. Jeremy asked the same question which I just raised. How long should we expect to decrease the head circumference?
If I add the excellent answer from Dr. Ramesh Tegla, of the two, if you take clinical versus radiological, clinical should be given more importance. There were studies in which they did regularly CT scan or MRI studies, and they found that they did unnecessary too much of ETV or reprocedure shunt. So clinical criteria is more important than radiology. The diminution in the size of the ventricle takes very long time. It may take very long time. So the radiological improvement may be delayed. The clinical is more important, but if you should take both of them, if there is a suspicion, then rely on both. And compared to lateral ventricle size reduction, the third ventricle size reduction is more important, number one. And rather than having these ventricle problem, I think more important in my clinical practice is that if you find the opening of the subarachnoid space after ETV, that shows that the CSF has come out of the ventricle and gone there. So initially there was collapsed subarachnoid space which opens up after some time, or if there's a periventricular lucency which has disappeared, although the ventricle size may not reduce. So some indirect sign also should be taken into consideration.
Thank you, sir. Dr. Swami, if you allow me, so can I take 2-3 comments on that? One,
please.
incision, regarding what you shown in one of the slides, you are given a vertical incision paramedian. So what is your common practice? Either you give a similar incision or a vertical incision, which one you prefer? Because commonly we use a semicircular incision so that flap will cover the burr side. It will have a better closure than a vertical incision, which has a high rates of CSF leak, what I personally observed in my practice. And I've seen most of the people practicing the same thing. And in addition to this, actually, one of the delegates has asked a question regarding CSF leak, especially in neonates or infants when you're doing an ETV. Skin and pericranium, we can raise the two different flaps in two different directions. When you close, we can reimpose them and take 1 or 2 stitches even for the pericranium, just like a double flap. So that can also prevent regular CSF leak, especially in the very tender kids when you're doing the ETV. That's what I personally observe. You take the pericranium also as a flap, and then when closing, you can put 1 or 2 stitches. Doesn't need a watertight closure, but approximating that thin layer over the burr hole side can also give an added advantage of preventing the CSF leak. You can answer for the skin incision, sir.
Yes, yes. So if I can show the slide, because of the lack of time, I did not play that
video. I think.
Can you see this?
Yes, sir.
I think. What is happening? Okay.
And for aqueductal stenosis admission, he was drowsy, hydrocephalus due to aqueductal.
Incision I am showing.
Supine under
So
anesthesia.
see this incision. We also give. I mean, this was just a diagrammatic representation which I was.
Okay.
So the incision given is curved. This is the trajectory towards in the sagittal plane. Not that it is going towards the ear. It is in the sagittal plane. You can go deep this side also entirely when the patient is draped, or you can go posteriorly. So in sagittal plane, you should be towards the external auditive matters. Then you will hit the, you will go at the foramen Monroe. But in coronal plane, you have to go medially. You cannot go laterally. It is impossible to hit the ventricle.
Yeah, one more comment here. Actually, your head gets neutral. What is your common practice? Do you turn the head to the opposite by 15 to 20 degrees? That's for the angle forms between the midline to the angle of the lateral ventricle. Because when you turn that much angle opposite, you can perpendicularly enter into the ventricle. In the mid-pupillary line is the one standard landmark which everyone takes from Nasion to Enian. Anywhere you hit the skull perpendicular to the mid-pupillary line, you tend to enter into the lateral ventricle. So that is another landmark to enter into the lateral ventricle, and from there you can have a track of undervision approach towards your foramen of Monroe and then to the third ventricular floor. So do you practice any tilt of the head or not, or you keep the ventricle, you keep the head in neutral position?
I keep the head in neutral position, but I flex the head just to make sure that the burr hole site is at the highest point. But for orientation, I don't rotate the head. I keep it straight in the neutral position.
Yeah. Okay.
I think Professor Ramesh's answer, the question was something like if it's a vertical incision as compared to circumferential incision.
Yeah.
There are papers on this, but then my sincere opinion is if the ETV is not working, whether it's circumferential or longitudinal, it's going to leak.
Yeah.
And if it's working, so
obviously there's no problem.
But if you raise a flap, he's right. It is better. Yes, better.
Closer will also be a little better, sir, because even a micro leaks through the subcutaneous leak also will be a problem.
Both of you are correct.
But one last question from my side, sir. What about your take on aqueductoplasty? Because if you see last 2 decades of practice, what I personally seen, you no more see huge neglected hydrocephalus in India, first thing. And second thing, in day-to-day practice, we are encountering more of a neonatal hydrocephalus because of the bleed or infection. That's not because with recent fetal medicine workup, most of the congenital hydrocephalus have been detected in the first trimester itself, and most of them, like meningomyelocele associated or a congenital hydrocephalus, have been detected before second trimester. And most of them, they go for termination. They are not letting the babies to deliver with these kind of morbid conditions. So at least for the last 5 to 6 years, we are not seeing those congenital standard aqueductal stenosis presenting in a neglected stage where you tend to operate beyond 6 months, 1 year, 2 years like that. So did you observe the same findings or not? One. And if you're doing a properly nice third ventriculostomy, do you still require to do any aqueductoplasty in case of aqueductal stenosis? Not the complete stenosis, even a thin membrane it is there. Is there any role for that, except in parasitic cysts which are blocking the stoma? You can clear them and the passage will be cleared. So over to you, sir.
Yeah, that is a completely valid thing. I don't do any aqueductoplasty because the rate of complication, except in a very small subgroup where there is a thin membrane. But if there's a long distance aqueductal stenosis and you try to dilate it, you create more brainstem problems rather than doing
Spectral plates.
so it is better to do ETV, and I don't do any aqueductoplasty except that thin membrane is there and you just break it with the catheter. It is all right. So this is regarding that question. What was another one? Whether you see neglected cases.
Hydrocephalus nowadays.
Yeah, we see most of them. We see poor patients. You see, the things might be different in big cities, but in our setup, the poor patient from tribal area, they come with very large head, neglected.
One more addendum to this, sir, especially neonatal hydrocephalus, because we commonly see them. IVH or infection, usually ventricular subgaleal shunt is one thing which probably it's good to add to the juniors, because age, when it comes to a parameter of selecting the ideal case for ETV, invariably younger than 3 months, it's unlikely that the ETV will work well. So in those cases, probably if the patient comes with these complicated hydrocephalus, ventricular subgaleal shunt is one excellent alternative temporary CSF diversion procedure, which most of the juniors can adopt before they plan for a permanent procedure like ETV or a shunt. So probably there's one thing which I think is good to add to your presentation for the junior psych at least.
So just one.
Can I add to your this about the aqueductoplasty? What Dr. Yadav said, that it is a long segment block. Obviously, long segment block is not very ideal situation for aqueductoplasty. But if it is a short block or the membrane, then I'm very comfortable doing aqueductoplasty along with ETV, because one is that you feel comfortable, you feel safe. Number two, what I feel is that because aqueductoplasty and rupturing membrane is more physiological, because that is the normal pathway of CSF. And doing ETV is not the normal pathway of CSF. It is, we are creating a bypass. That is the difference. So one should not, in my opinion, hesitate doing aqueductoplasty when it is short segment or a membranous aqueduct. And if you can do it safely, then one should do it.
Simple physiological understanding is, if you have a working aqueduct and the normal passes, the flow across the stoma will be reduced, and once there is no flow, it tends to close. That's what the common physiology. So when you get a case of aqueductal stenosis, our first attempt is to do the ETV. If you have a successful ETV, you can do the aqueductoplasty or not, it's immaterial. But if your aqueduct plasty is opening, probably your stoma is tend to close soon because the flow can be bypassed through that. So only when you have a flow, CSF flowing, then it will get epithelialized and the stoma will be patent. Once there is no flow, then it tends to close in a natural process. That's what the general physiological process, what it happens. That's why I asked that question. What is your take on doing a regular aqueductoplasty, even in a thin membrane aqueductal stenosis? So your question is very well taken, the answer. So this is what the physiological explanation for that.
So I
Thank
have
you.
two questions to ask to Dr. Yadav. So congratulations for a wonderful presentation as always. One is like as the age decreases, the success of the ETV it also like decreases. So do you have any cutoff age for ETV?
No. I mean, not that. I mean, you want to say that the extreme age infants and the elderly also the success decreases. We hardly get the proper case in the elderly, except you can say that NPH. NPH may be
I'm asking for infants like.
Infants you are talking?
Yeah. Like
as
the
age increases.
Decreases, like the.
Decreases. Yeah, you are right. I mean, there are reports, but we have not found it significant. We do it at just on day one. We have not done it antenatal, but if anybody comes with the hydrocephalus, we operate. We have analyzed our results of ETV in infant and published also, and we found that the patient subgroup in which there is a low birth weight, we found them significant low birth weight, malnourished patient, premature infants. So success rate in premature infants, malnourished infants are poor compared to those who are well nourished and full term. So in our study, there was no significant difference between the age and the ETV.
So the second thing is like mostly we are making the hole in the tuber cinerarium, the thinnest part in the tuber cinerarium is the typical location of the hole to be made. So, sir, do you have any experience of making a hole in the lamina terminalis while doing ETV?
I did not do it because for that I think you need a flexible scope. But to be very, I mean, frank, I have not used flexible scope. When we had the flexible scope, the quality was poor, and now when I found that there is a problem in the floor, then most of the time the ETV usually does not work, except in situation in meningitis where the lamina terminalis can be opened up. So I have no experience, but the literature says, and I think Dr. Subodh Raju also, or Dr.
Yeah, I did couple of cases because we have the flexible scope we regularly do when we don't get the proper anatomical landmarks in the standard third ventricular floor. We can approach that or go posteriorly and try to communicate into the other systems if it is possible, because we want to do the endoscopic third ventriculostomy in infected case or where shunt failure rates are very high. Then we try to find out a place where you can do the endoscopic third ventriculostomy. Most commonest will be the lamina terminalis. I have an experience of couple of cases. It does work, but usually 99% of the cases, you don't need to go beyond the standard third ventriculostomy. That's what is my experience also.
Thank you.
Thank you, Dr. Ramesh. The last question is there. Which is the best position in case you do two borehole, one for ETV and one for biopsy? Dr. Rishi, anybody who can take Dr. Rishi?
So I think I have addressed that if you have large foramen Monro, that means a large ventricle, in those cases, even single borehole may be in between. So you make a line for ETV and make a trajectory for biopsy, and exactly in between these two you can make, if you have a rigid scope, So large foramen Monroe, even burr hole, single burr hole with the rigid scope is all right. But if you have facilities of flexible scope, which is giving good quality, then in any case, you can have ETV and biopsy with a single burr hole. People have described a sort of elliptical thing, or a single incision and two burr hole, one for ETV and biopsy also. So different combinations are there. If you have a large foramen Monroe, one single burr hole for both can work, because you can move your scope a little bit. If you have flexible scope, obviously with whatever small or large foramen Monroe, you can do both the things. Okay. Or
So
you can two burr holes. Yeah.
you want to know, in that case, if the two burr holes are made, what is the best position? In the sense, should it be supine or should it be
No, it is always supine. Yes,
supine?
supine.
Hope, Dr. Jan, you are answered.
Can
So
I,
that
can
means
I
no
ask-
question, sir. No
No,
question.
no, no.
Yeah,
About
sir.
one thing that Dr. Yadav, have you used two scopes? Like if you are using LOTA system,
Scope in
and
scope.
then
Scope
if
in
you
scope.
use
Sir.
LOTA, because LOTA has more diameter, and then you use the GAP system so that you can go posteriorly. You can do ETV with one, and then because that the trajectory will be more dilated. So then if you use the GAP, which is the smaller in diameter than LOTA, then you can go posteriorly. So then the chances of damaging or injury or bleeding would be less. Have you used any time this?
No, sir, not this one, but people have described scope in scope. So that means there is a rigid scope, and then through the working channel of rigid scope, you pass the flexible scope. So do one thing, I mean, maybe ETV or biopsy, whatever, with that scope and with the flexible scope. In that case, what they do is that they keep rigid scope at the foramen Monroe so that there is no injury, and then take it in the third ventricle, the flexible scope, and move the way you want. So that is known as scope in scope. This is more useful when you want to go in the posterior fossa through the aqueduct also.
Transaqueductal procedures. And mainly, I think that Suri described it for neurocircle removal through the fourth ventricle.
Yeah. But I think they are not advertising these people the chip on tip. So once we get this chip on tip easily available, that
chip on tip
will
is
be the
available,
best.
sir. Nowadays, GAB is not available. So they stopped the GAB manufacturing. You get only two, little LOTA and standard LOTA nowadays. So
Okay.
stores one actually. So we need to use them only. When we had the GAB system, it was good to pass on the catheters also, because we used to send a lot of foramen Monroe transaqueductal stents where there is a fourth ventricular outlet obstruction, a trapped fourth ventricle. That also we used to do. Through the LOTA system, it's very difficult to pass the catheters through the working channel actually. So I don't know, some reasons stores is not marketing the GAP system nowadays. Those older people who kept it, it is available, but new, if you want to purchase, it's either a little LOTA or a standard LOTA from the stores at least.
GAB basically it tends to break. I have GAB also and LOTA both, but the old one maybe they are not marketing now.
Yes, sir.
Yeah.
Because it's an open channel, working channel, so it's easy to pass the catheters at least to manage those trap, fourth ventricular trap, lockleted cyst when you want to break them.
Even with the even with the LOTA system also, you can put your working channel posteriorly, number one. Number two, you curve the tip of your the tip of the catheter sometime, which is used in urology and other cardiac people. So we borrow from them. You can bend the tip and manipulate it, I mean, negotiate inject it through the aqueduct of sylvius. It is possible. We use it for neurocysticercosis.
Since Dr. Hemal Bhartiya said he does aqueductoplasty repeatedly, Dr. Vijay Seth wants to know, in case if you've done third ventriculostomy as well as aqueductoplasty in your long-term follow-up, how has the third ventriculostomy stomach closed up because aqueduct is opened up now?
See, it is very difficult to find out which is working and which is closed unless you do imaging and the contrast scene imaging you do and see how much which is working, which is not working. In our setup and our practice, we usually don't follow up like this. But what Professor Ramesh said, that if you have done both, then ETV might close because the CSF might flow from the aqueduct or whatever it is. But what I feel is that there may be some CSF going through the ETV also, at the same time some CSF going through the aqueduct also. So the only point of doing it was because that is the physiological pathway of CSF flow. So that anything which is physiological and anatomically correlating, so that would definitely work better than what ETV would work. That's what is my feeling. And wherever I have done, what is Vijay said's question, wherever I have done aqueductoplasty along with, I think we have got better results than doing only ETV.
Yeah,
Thank you,
so
sir.
both of you are correct. Both Dr. Ramesh Tagla. The literature says that patent aqueduct is a risk factor for closure of ETV. So this is very well documented. But you are also right, sir, that it is more physiological and nobody knows which is working, which has failed. But I think now people are not doing more aqueductoplasty. I mean, it is rare except for very thin film. See, I mean, very film-like membrane. Your experience obviously is better. I have not done it, sir.
The literature says
Flexible
that
scope, sir.
the
Biggest
gray matter
limitation for
surrounding-
doing it. Biggest limitation for doing aqueductoplasty is you need to have a flexible scope, you have a proper assessment. So rigid scope always overstretching and overfolding can cause corneal injury. So flexible scope is now available with very few centers. So many people, they are happy with doing ETV and just close it in, I understand.
Yes,
No,
Dr.
I
Sir,
have-
we already pointed out, tectal plate injury as well as the gray matter surrounding the aqueduct. Long term, they produce spasticity and then because of injury, all long track signs. So we have finished this particular question answer session, sir.
Okay, then we must thank all the panelists and John sir. So over to you, John sir.
Thank you, sir. Thank you for the excellent presentation. And thank you, the panel. Thank you, panelists, for joining us and making this wonderful session.
Thank you very
John?
much.
Yes, thank you very much, everyone. That was a very interactive session once again, contributing to education in neurosurgery. I appreciate that, Dr. Yadav. And next week, endoscopic management of deep-seated intraparenchymal hematoma and tumor. Correct, Dr. Yadav?
Yes, sir. Yes, sir.
Okay,
Yes, sir.
great. Okay, we'll see you all next week.
Okay, thank you. Good night.
Thank
Good morning. Thank you, sir. Thank you.
Thank you.
Good night.
Good night.